This session is a thank you, Usman, Asad, and Dr. Bashirani for joining for this session as panelists. This session is a follow-up to the previous session, जो था जिसपे talk थी over update on imaging and coronary physiology guidelines. So in Pakistan, so that we're just sharing some cases for practical use of this thing. So and then we'll get an input for the panelists later on. So I guess पहले cases जल्दी से दिखा देते हैं वरना session में complete नहीं होंगे. फिर उसके बाद जो है we can have discussion and panelists can jot down their points regarding the cases and thoughts about how they would have done differently. Yeah, what their thoughts are about imaging and physiology used in their centers. And तो चलें सोहेल with that आप शुरू कर दें फिर.
Okay, Assalamu alaikum ji. Thank you very
Dr.
much.
Sohail Rashid is an interventional cardiology consultant at Bahria International Hospital and very competent. और मेरे साथ अक्सर cases में इनमें involved रहे हैं साथ. तो that's why he's presenting over here. Thank you for doing this.
Welcome, sir. First of all, I would like to thank Professor Dr. Noman Nasir for giving me an opportunity to present a few of his best imaging and physiology guided intervention cases at this esteemed forum. So with the permission of the panelists, I would like to start. So my first patient is a 70-year-old male, diabetic, hypertensive, and family history was positive. He was an ex-smoker, presented with non-ST elevation MI, status post-PCI to LED, circumflex and RCA in May 2019 after cabbage was declined. IVUS was done at that time, showed left main minimal luminal area of around 6 millimeters squared, and EF was 55%. This is the angiogram. The previously placed stent in RCA looked okay with mild diffuse disease. There was a moderate stenosis in the left main, and ostial circ also was looking severe in the caudal views. So we did FFR and IFR of left main, which came out to be non-significant. IFR reading was noted at 0.91. FFR was noted at 0.85. And circumflex, regarding circumflex ostial lesion, the pre-IFR of circumflex lesion was around 0.87, and the FFR was 0.79, which was coming in the significant range. So based on this, we deferred left main stenting and we went for drug-eluting balloon to the osteoproximal segment of that circumflex osteoproximal lesion with nice decent result, as you can see on the angiogram. So concluding this case, FFR, IFR was helpful here to guide the planning of the procedure in the presence of intermediate left main stenosis. My second patient is a 53-year-old female, non-diabetic and hypertensive, previous history of NSTEMI 3 months back, now recurrent chest pain and angina class 3, echo showed preserved ejection fraction. This is the angiogram showing multivessel CAD. Circumflex was totally occluded proximally. LED had severe calcification proximal to mid segment with severe lesion angiographically, which was also giving collaterals to the occluded RCA. And on the lower, you can see RCA had a severe proximal to mid lesion followed by total occlusion. Now, this was essentially a multivessel CAD. In this case, we did IFR and FFR of that LED lesion. It came out to be significant at 0.57 and 0.77 respectively. So first went with, as the patient already had declined cabbage, we went with opening of that RCA lesion first, and we repeated the IFR of that LED. So there were two sequential lesions in the LED. The mid lesion was coming out significant, while the proximal lesion was not coming out significant. So that's why only the mid LED lesion was stented in this case. So concluding this, FFR and IFR play significant role for planning of treatment in borderline lesions in case of multivessel coronary artery disease and segmental lesions, as in this case. My third patient is a 65-year-old male, non-diabetic, hypertensive, smoker, non-CKD, previous history of anstomy 1 month back, now referred by cardiac surgeon for FFR and IFR of that of LAD, which was which was concerning echo EF of 55% with no significant valvular disease. So on angiography, LAD lesion appeared borderline at bifurcation point with a prominent diagonal branch. There was Shepherd's crook RCA with severe mid stenosis. PDA also was severe and borderline circumflex. This was the angiogram. The circumflex lesion was borderline, and on the caudal view, you can appreciate that LAD diagonal bifurcation looked severe angiographically. So we did IFR and FFR of LAD, and it was significant as shown over here. FFR was recorded at 0.79, and IFR reading was recorded at 0.78. We did FFR of circumflex lesion, which was 0.89, and IFR was 0.92, which was non-significant. So that patient actually was advised CABG based on this, and patient decided for CABG after heart team evaluation, and he underwent CABG successfully. So IVUS and FFR, IFR and FFR play significant role for revascularization planning in case of multivessel CAD and borderline lesions. My fourth patient is a 34-year-old male, history of anterior wall MI in April 2016, status post LAD PCI with a 2.5 millimeter Zeiss at outside facility. He had recurrent MI the same year with angiography showing thrombus in the previous stent. He was treated with anticoagulation at other facility. According to the report, a relook angiography showed resolved thrombus. So now he presented to us with acute coronary syndrome in 2017. EF decreased to 35% from 50%. Angiography was done, which showed filling defect in the stent again. So here it is not better appreciated in the caudal view, but on the cranial view, you can see there is a filling defect in the proximal LAD at the level of that septal branch. We did an IVUS study. Unfortunately, the image is not playing over here. Underexpanded malapose stent in proximal LAD. Vessel diameter distal to the stent was 3.6 millimeter, and proximal to stent it was around 4 millimeters. And there was 2.5 millimeter Zeiss stent that had been placed in this vessel previously. So our plan was to go with PCI to LAD, COBA within the stent, and stretching 2.5 millimeter stent to more than 4 posed a risk of stent fracture. So that's why we decided to place another DES. So we went with a DES 3.5 into 18, and we post dilated it to 40 with 40 NC at 20 atmosphere as per the IVUS guidance. So this is the final angiography of that after stenting. So concluding this case, patient with stent failure, I was provided valuable information and helped in treatment plan. My next patient is a 78-year-old male, non-diabetic, hypertensive, ischemic heart disease, and recent ischemic CVA, presented with non-ST elevation MI and pulmonary edema, normal LVEF, and no significant valvular disease. Coronary angiography showed left main bifurcation lesion. Patient declined CABG and opted for PCI. So this is the angiogram. On the caudal views, you can appreciate distal severe left main stenosis involving the ostium of LAD and circumflex. So it was a true bifurcation lesion, Medina 111, and RCA showed non-obstructive mild disease. We went with a mini crush bifurcation stenting of left main bifurcation lesion, followed by pod with a 40 millimeter NC balloon. On the right, you can see result after that. We did an IVUS study of that, which showed stent appeared well expanded in the LAD portion, but under expansion was noted in the left main area. So this IVUS study is playing. This is the left LAD stented area, which appears well expanded. Now it's coming back in the proximal LAD, which also appears well expanded. And in the left main area, it appeared under expanded here. So based on this, we did report of that left main with a 4.5 millimeter non-compliant balloon as per IVUS guidance, showing us recent final result. There was mild to moderate residual lesion in the LAD and circumflex after the stenting, which was left on medical treatment. This was repeat IVUS, which showed well expanded stent with a minimal luminal area of around 12 millimeter square with good stent opposition now. This is the left main area. So previously, these were the cutoffs for that left main. It was around 8 millimeter square. And now it has been upgraded. I think it's around 11 millimeter square for the left main, 8 millimeter square for LED proximal, and 5.7 millimeter square for circumflex. Concluding this, IVUS is very helpful in stent optimization in the complex left main intervention, as in this case. My next patient is a 44-year-old male, is a non-smoker, family history was positive, dyslipidemic, recent episode of CO poisoning followed by upper respiratory infection, which he recovered. After that, the recovery, he had troponin done, which was borderline positive, and on follow-up trending down with unremarkable ECG and echo. He had CT angio done, which revealed moderate left main disease and a severe proximal LED disease. So here you can appreciate severe osteoproximal LED stenosis, and left main appeared moderate in different views. Right coronary artery was non-obstructive. We went with IVUS study of this lesion. The left main actually showed significant plaque burden with plaque burden of around 70 to 75%. On the right, you can see minimal luminal area of 5.4 millimeter square in this left main. So based on this, we went with stenting of that left main lesion as well, which initially we were thinking to go with LED only. So we did stenting of that LED lesion followed by left main to LED lesion using provisional technique, showing us good final result in the end, as you can see on the final images down. IVUS played significant role in planning for PCI of osteoproximal LED in this case. It was helpful identifying the plaque burden in distal left main and changing our strategy to left main LED PCI. My next patient is a 74-year-old male with a history of recurrent angina and STEMI in 2021. He is non-diabetic, hypertensive, status post PCI to circumflex in 2008 and 2017 at another facility. He is non-dyslipidemic. This is the angiogram. The LED ostial lesion appeared moderate. There is a haziness in the mid circumflex where the previous stent was placed. If you can see in the ariocaudal view, it can be appreciated better. Right coronary artery was non-obstructive.
So this is a pullback from the distal left circumflex. अभी शुरू होगा pullback. उधर ही कैथेटर खड़ा है. हमने कहा जाके कैथेटर की आपको पता लग जाता है अब IVUS भी देख लिया करो. पुल बैक कर रहे हैं. Stented segment नजर आ रहा है. तो over here it looks like a well expanded stent and well opposed as well. और यहाँ पे आपको ये plaque नजर आ रहा है इंटमा में. The stent looks well opposed and reasonably well expanded as well. ये अब आपने contrast दिए. यहाँ पे under expanded है और mal opposed भी है. ये देखें contrast जब दिया था तो stent के पीछे भी नजर आ रहा है. ये वो area in between the stents जो कि stented नहीं है और दोबारा ये proximal vessel का stent नजर आना शुरू हो गया. Which looks well opposed and
so we went with stenting of this lesion. We placed another dash in that left circumflex with a good result angiographically.
The post intervention ये बिल्कुल post standing वाली एरिया के just उधर से start कर रहे हैं. So you have a nicely well expanded stent with no malapposition noted. ये कैल्शियम की वजह से आपको यहाँ पीछे गैप नजर आ रहा है और इस जगह का एरिया भी जो हमने कैलकुलेट किया है वो 6 पॉइंट कुछ आ रहा था वर्सेस 3 पॉइंट कुछ बिफोर. यहाँ पे भी यू कैन सी दैट एरिया बहुत अच्छा आ जाता है इसका और इट्स लुक्स वेल अपोज्ड थ्रूआउट. ये डाई डाल के देखें. इधर इस स्पॉट पे लगता है कि जो पिछला स्टेंट और स्टेंट के दरमियान हल्का सा गैप है. And you could see when you injected the saline over here, तो ये bubbles पीछे नजर आए थे. इस spot को थोड़ा सा रेड कर देते हैं. Lumen area बड़ा अच्छा है, expansion अच्छी है बट स्टेंट ऑपोजिशन भी थोड़ी सी और बेहतर हो जाए विल बी नाइस। तो यहाँ पे इसको थोड़े से हाई प्रेशर पे ऑपरेट कर देते हैं। तो ठीक है।
So that minimal luminal area improved from 3 millimeter square to around 7 millimeter square using this IVUS. So IVUS in this case was very helpful for identifying the mechanism of stent failure and its treatment. My next patient is an 80-year-old female, non-hypertensive, asthmatic, ischemic heart disease on medical treatment, previously admitted with troponin-positive ACS. Coronary angiography showed borderline ostial LED stenosis involving 40 to 50% of distal left main stenosis, moderate circumflex osteostenosis, small AV circ with severe stenosis, RCA with moderate stenosis involving RPD ostium. Preserved EF on echocardiography with no significant valvular disease. She was advised CABG but declined by the patient and family. So this is the angiography. So you can appreciate a distal left main lesion which looks borderline. Ostial LED lesion looks severe on angiography, and circumflex ostial lesion also was borderline. The right coronary artery was non-obstructive with moderate distal disease. We went with IVUS and IFR of that LED lesion. The ostial LED IFR came out to be significant, 0.85. MLA of ostial LED was calculated at 3.8 millimeter square with calcified mixed plaque, a significant plaque in left main. So we went with stenting of that lesion. We used NC 2.5 to pre-dilate the lesion, used a DES Science Expedition 3.528 with a provisional technique. We did POD with a 4.5 NC based on this IVUS. Subsequent circumflex ostial pinching was noted, as you can see in the aleocaudal view on the right. And its IFR was done, which came out to be significant. We did recross and opened the struts and then went with drug-eluting balloon to that circumflex ostium with support C3010 balloon, followed by kissing balloon inflation of with a NC Sapphire 3.5 10 from left main to LED, and repod was done with a 4.5 balloon at 18 atmospheres. This was the final IVUS. We showed good MLA, very well expanded stent in the left main with MLA of 16 millimeter square. Concluding this, IVUS and IFR were of great value in deciding intervention strategy in this borderline left main and circumflex lesion. My next patient is a 79-year-old female, known hypertensive. Family history was positive for ischemic heart disease. She presented with non-ST elevation MI with Wellens T waves. Coronary angiography at our outside facility revealed borderline left main disease and obstructive proximal LAD, which was likely culprit, and also ostial circumflex, which was concerning but not clear in views taken there. Dominant RCA was non-obstructive. She was advised both PCI to LAD by one and also CABG by another cardiologist. She came to us for further evaluation. Family wanted a clear picture of the coronaries and proceed. So we planned for FFR and IFR of circumflex and then proceed. So this was distal left main lesion, which looked borderline. There was an ostial circumflex lesion and proximal LAD, which likely was culprit over here, looks severe. This is IFR reading of that circumflex, which is 0.81, and IFR of LAD was 0.51. So both were coming out to be severe. We went with bifurcation stenting of this lesion using mini cone crush bifurcation technique using Orsiro 2.518 in circumflex and Science Expedition in LED 3.548. Pod was done with 4 NC at 16 atmospheres. Followed by kissing balloon inflation with Sapphire NC 3.25 in left main to LED and 2.5 in circumflex at 12 atmospheres each, and repod was done with a 4O NC at 18 atmospheres, showing us decent final result as you can see over here. Intracoronary physiology was very helpful for deciding treatment strategy about this left main bifurcation lesion. My next patient is a 62-year-old male, known diabetic, smoker, obese with family history positive for CAD, admitted with non-ST elevation MI. Echo showed good LVEF. Coronary angiography showed tight ostial LED stenosis involving distal left main, followed by tight mid LED stenosis at bifurcation point with a prominent diagonal branch. RPD also showed tight proximal stenosis. He was advised cabbage, but declined by the patient and family. He now came for multi-vessel PCI. So you can appreciate LED ostial and mid bifurcation lesion. Ostial was severe, mid bifurcation was Medina 111, classic bifurcation lesion. We went with mini cone crush bifurcation stenting of LED diagonal bifurcation lesion using Zeiss Expedition stents, followed by left main to LED PCI with another Zeiss Expedition, which was 30 into 33, using provisional technique, followed by part of that left main with an NC Sapphire 40 into 12 at a 14 atmosphere, and kissing balloon inflation was done in the LED. Part of proximal LED was done with 2.7515. So this is the final result of that LED diagonal bifurcation and left main ostial LED lesion. So MLA was coming around 6 millimeter square in the ostial LED lesion, while in left main it was around 10 to 11 millimeter square. I was helped in stent optimization in this complex bifurcation lesion. My next patient is a 70-year-old male, non-smoker, family history was positive, diabetic and hypertensive, EF of 50% with moderate MR. He actually had detailed history, including ischemic heart disease. First episode was in 2019, status post LED PCI. Then he underwent cabbage in 2023 with SVG grafts to LED, RCA, and circumflex, and followed by left main LED PCI in January of 2024. Post-cabbage CT angio was done, which showed only SVG to RCA was patent, and that too was having a severe lesion, which we stented initially. And SVG to circumflex and LED both were occluded. So option of redo cabbage versus PCI was discussed in this case. In Feb of 2024, he underwent PCI to left circumflex and left main bifurcation using mini crush technique and using IVUS. Current presentation to us was with exertional angina, class 2 to 3 for a couple of weeks, and he was admitted with NSTEMI. EF was preserved as previous with moderate MR and mild pulmonary hypertension. So this is the angiogram of that left main bifurcation lesion. You can appreciate left main bifurcation ISR lesion, severe distal left main, severe ostial LED, and severe ostial circumflex lesion. On the cranial view, you can see LED is totally occluded and continuing as a prominent diagonal branch. This is the SVG to RCA, which was previously stented. So its relook angiogram showed patent stent. And native RCA had a severe proximal lesion and total mid occlusion, and its RV branch was actually filling that LED. So we had to do, we went with kissing balloon inflation of left main bifurcation ISR. We are first with Sapphire NC 3.515 from left main to LED and 3 to 510 from left main to circumflex at 18 atmospheres each to prepare the lesion. And on the right, you can see angiography result after that NC ballooning, followed by kissing balloon inflation with drug-eluting balloons using Protease DEB 3.515 from left main to LED and support C 3 to 510 from left main to circumflex at 14 to 16 atmospheres each. I think it's not playing. Let me play it manually. Hopefully it can play. So on the right, you can see the result after that drug-eluting balloon, followed by pot with 4.515 NC. And this is the angiographic result after that, which looks quite satisfactory. So this is the IVUS run after that, which shows good MLA in left main, which approaches around 16 to 17 millimeter square with very well expanded stent throughout. IVUS was again very helpful for optimization of this left main ISR lesion. My next patient is 57-year-old female, non-diabetic, positive family history, ischemic heart disease, recently had inferior wall MI, thrombolized with streptokinase, and coronary angiography was done, which showed multivessel CAD and was advised CABG. Patient declined CABG and opted for multivessel PCI, EF of 60% with no significant valvular disease on echocardiography. This is the angiogram of right coronary artery, which showed total distal occlusion. So first we went with PCI of that lesion, which was kind of straightforward, showing us decent result in right coronary artery, as you can see in the LO view on the right lower corner. Followed by that, we went with guided to that left main. So LED showed tram track heavy calcification, as you can appreciate on the LO caudal view. And IVUS study showed a 270 to 360 degree arc of dense superficial calcium. So we went with rotablation of this lesion. So upfront rotational atherectomy was done with a 1.5 millimeter burr, followed by stent deployment in LED. On the right, you can see that LED stent that deployed very well with no residual waste. And now angiographically it appears okay, but with mid LED stent appeared underexpanded at multiple spots, with minimal luminal area coming around 3.5 to 4 millimeter square at several points. So we decided to do post dilatation of that stent again with Sapphire NC 3.25 up to 18 to 20 atmospheres. And now this is the final angiographic result, which looks quite satisfying. So IVUS again was very helpful in this case with stent optimization. Thank you very much.
So thank you, Dr. Sohail, for an excellent presentation. It's not easy to cover all these cases within half an hour. So I think we'll open the floor to discussion and comments from the panelists. And do we have Dr. Bashir Anif there?
Yes, I'm here. Thank you, Naman. Excellent, actually, demonstration of all the physiology, including IVUS, FFR, and IFR. I think all these cases really tell you how important it is to help make decisions for optimum management of any patient with the CAD, especially when you're performing the left main interventions. Although all of us know that the new guidelines actually suggest 1A indication for using IVUS in all the cases. But unfortunately, in our setup, obviously, cost really becomes a really limiting factor to use IVUS, FFR, or IFR. And but still, I think left main and left main bifurcation lesions definitely should not be performed with IVUS. And when you're performing again multi-vessel PCI, FFR, IFR is very helpful. I just had a question. Actually, one of the cases, again, I don't remember, Swale, I think you saw that there was a right was occluded and there was good collaterals going from the LED to the right. And you decided to perform the FFR or IFR of
That's
that.
the second case.
Yeah, it was second case. So do you think?
Yeah, I had a question about that too.
Yeah, because with that, those so good collaterals, obviously that FFR, obviously if it is negative, that is helpful. But if it is positive, that's not going to really help you much. So why was that done?
Let me go to that.
So there was a right was fixed in that case, and the
No,
FFR, IFR of the
FFR,
LED was
IFR.
done.
No, one
Yeah,
FFR, IFR was done before fixing the right.
Yes.
Yeah,
So, and then we fixed the right, and it was done again actually. And during the LED intervention, also we did FFR and IFR. In that case, actually that helped us with the segmental lesions as well. There was a lesion close to the bifurcation, and there's a lesion in the mid LED. So we fixed the mid LED lesion and repeated the IFR FFR of the LED, and then it became non-significant. And that's a very good point that you made, that if the LED is supplying collaterals to the right, so it will be more significant lesion. Once you fix the right, it may not remain significant. A lot of times we see that if there is an FFR, let's say was 0.79 on an LED lesion, which was supplying collaterals to the right, once you fix the right, then that lesion may become 0.82 or 0.83 and non-significant because the hemodynamic significant lesion is not as much and you may not need to fix it. But it was still significant. We actually repeated it, and that's how we decided to defer the bifurcation lesion, because we didn't want to do that bifurcation area unless it was hemodynamically significant. So in that case, we just fixed the middle ear. But the FFR was done not just in the beginning, but also later on, it continued to be significant. He has not put it down over here, but it was significant during.
Okay, my question is there any point of doing it before? Does it help you in any way in making that any of the decisions? Because if you have to do it after fixing right, then it's fine. But before fixing right, as I said, if it is positive, negative, then it's helpful. But if it is positive, then you can't say anything.
So positive say is helpful tha कि we did give the option of cabbage कि भाई LED although right को supply कर रही है, but it's falling in a significant range, and they didn't want cabbage, so we went ahead with fixing the right first.
That's absolutely fine. But I would not, even if it was positive before fixing the right, I would not take that as positive until and unless I fixed right, because it is supplying such a huge area that positive is not going to help you in deciding that if LED lesion is significant or not. As I said, if it is negative, that's fine. But if it is positive, that's not going to help me at all.
So you're right. इस पे family ने stenting के लिए जाना था, but I guess the question is कि अगर LED का lesion जो है FFR IFR पे significant आता है for somewhere where somebody is a CTO right and LED is a borderline lesion, and the family doesn't want और उसको आप surgery और stenting option देते हैं, तो I think surgery की तरफ उस scenario में भी जाता है, तो it's a reasonable thing to do.
What would you do? I would be reluctant to do before fixing the right FFR IFR.
लेकिन मेरा ख्याल है कि if the family wasn't going for cabbage, तो you were going to fix this anyway. Probably, I think what you did afterwards corrected the whole thing. कि you did an FFR afterwards as well, and that helped you sort out which lesion in LED you guys needed to fix. Lekin I think doing it beforehand, for me, that was the first thing I had written in my comments as well. That I won't have I don't think that you were gonna add much before fixing the right if you were doing it just to find the significance of that LED lesion. Lekin I think you did a wonderful job by making sure that the prox or this mid LED bifurcation lesion wasn't significant by doing an FFR after fixing the right. So that's where it really helped. But I think
पहले करके definitely that is a very valid point कि the FFR improves after you fix the vessel. If you fix the donor vessel, तो जो है वो and it's supplying collaterals, तो जो feeding vessel है उसको आप fix कर देते हैं, जिस तरह CTO right था इसमें हो रहा था, तो उसमें FFR does improve, but it still remains significant. But पहले करने का यही था कि अगर तो it doesn't really help unless you have somebody for cabbage consideration. तो उसमें भी आर्गुमेंट है कि भैया आपने अगर राइट क्राफ्ट हो जाती है तो एलईडी सिग्निफिकेंट नहीं रहती, तो दैट्स अ ग्रे एरिया इन टर्म्स ऑफ डिस्कशन वेदर उसमें आप ऑफर कर सकते हैं. बिल्कुल, दैट्स अ वेरी वैलिड पॉइंट. बिल्कुल.
Just want to give the message to the people listening that I think if a vessel is supplying collaterals, significant collaterals to another territory, then you should not rely on FFR or IFR
of the feeding vessel. You have to repeat the. You should not. Yeah, you should have to after fixing the.
It's better to fix it and then do it and then decide about that vessel.
Absolutely.
Last quick comment I would like to give, that it is very important to know all the pitfalls of FFR and IFR before really, right? You should understand the basic physiology of the waveforms and all that drift, and making sure that your guide is outside the left main when you are doing the left main FFR, IFR, and you are doing equalization when your guide is outside the left main, and those kind of things are going to be very, very important, and you really need to understand. I'm sure probably we're going to discuss those things in the talk coming up.
हाँ, वो पिछली टॉक में सारी चीजें बड़ी वो की थी डिस्कस, बट दैट्स वेरी वैलिड पॉइंट के द पिटफॉल्स स्पेशली फॉर आईवस में जो इमेज आप कहते हो फ्लोट करते हो नजर आ रहा होता है, बट आईएफआर में रिकॉर्डिंग्स आर वेरी क्रूशियल, वेरी इंपॉर्टेंट पॉइंट. एंड कॉमन पिटफॉल्स आर के एक तो आपकी अगर वायर कहीं छोटी ब्रांच में वेज्ड है तो आपकी वायर छोटी ब्रांच में तो उससे आपकी आर्टिफैक्ट काफी आता है, तो उसमें आप एडजस्ट कर सकते हैं. दूसरा वेरी इंपॉर्टेंट पॉइंट, अगर आपका गाइड एंगेज्ड है लेफ्ट मेन के साथ और आपका उसमें वो वेज हुआ है, तो यू मे गेट लोअर आर्टीरियल प्रेशर, एंड दैट्स तो आपका जो एफएफआर है वो सिग्निफिकेंट नहीं रहेगा, वो इतना डिफरेंस नहीं रहेगा। तो यू हैव टू बी केयरफुल कि आप गाइड को डिसएंगेज हो थोड़ा सा, या वेजिंग ना हो उसकी, और उसकी आर्टीरियल ट्रेसिंग बिल्कुल सही आ रही हो। एंड तो वो बड़ा इंपॉर्टेंट पॉइंट है कि गाइड वेज ना हो और वेंट्रिकुलाइजेशन आर्टीरियल प्रेशर की ना हो रही हो, और डिसएंगेज करके तो उसको करें तो बेहतर रहता है। दूसरा, लॉट ऑफ टाइम्स यू हैव टू वॉच फॉर ड्रिफ्ट व्हेनेवर यू डू एन FFR रिकॉर्डिंग, पुल द वायर बैक जो प्रेशर ट्रांसड्यूसर का है up to the guide catheter tip and make sure the pressures are still equalized, and the drift has not taken place. Modern wires में अब जो है recently मैंने नहीं देखी कि drift होते हुए, पहले जरा ज्यादा देखते थे, बट फिर भी चेक करना चाहिए आफ्टर ऑल योर रिकॉर्डिंग्स कि जी आपकी रिकॉर्डिंग सॉलिड थी और ड्रिफ्ट नहीं हुई उसके साथ। और जो है अपना डेफिनेटली पहले आप जब जीरो करते हैं तो कॉइल में रख के 30 सेकेंड्स फिर आप हुकअप करें, और फिर इक्वलाइजेशन के लिए बटन दबा के, तो उसमें इक्वलाइजेशन के वक्त इंपॉर्टेंट पॉइंट है कि आपने जो डाला हो इंसर्शन टूल जिससे वायर लेके जाते हैं उसको बाहर निकाला हो, और सेलिन के साथ फ्लश करके स्टेबल चीजें रख के तो फिर आप इक्वलाइजेशन का बटन दबाएं ताकि गेट अ प्रॉपर इक्वल रिकॉर्डिंग। सो दीज आर वेरी इंपॉर्टेंट क्रूशियल, ये 2-3 पॉइंट्स जो कि रिकॉर्डिंग के वक्त बहुत इंपॉर्टेंट है, एज बशीर साहब पॉइंटेड आउट एज वेल, फॉर प्रॉपर FFR IFR रिकॉर्डिंग। तो हाँ जी, उस्मान, आप एनी थॉट्स फ्रॉम यू?
Gee, I think first of all, great presentation. Really went over a lot of cases in different scenarios and use of IFR, FFR, and IVIS. I think there were two cases where the stents were undersized, and I think both those situations, the treatment that was used was another stent within the stents. एक तो LED का था, I think, which was a 2.5 millimeter stent in a vessel where the reference vessel size was 4.0 or greater. So the question was, why not just balloon it, re-IVIS it, and see what kind of result you get? And then the other question was, if you do end up stenting within a stent that may have fractured because of, it was a smaller stent, so now you have a fractured stent under a GE wala case. So I'm not sure how that affects, there is a lot of metal there. So just thoughts from the group. One, do you always stent undersized stents again, or just balloon them and reevaluate? And second, a stent that's so undersized, 2.5 in a 4.0 vessel, that would obviously get fractured if you take it to 4.0, would be my question. How does that affect long-term issues?
So for a stent which is really undersized, जिसमें इस तरह था कि stretching a 2.5 to a 4.0, there's a very high likelihood that it will fracture, and so that's why we went with another stent over there. And obviously अगर तो duration जो है drug loading stent का is within the short period, तो जिसके लिए आप दोबारा balloon करना पड़ रहा है, stent thrombosis है कुछ, तो उसमें तो फिर you can just go with simple ballooning, but otherwise there's always that risk that when you just balloon the stent that you may initiate, if you're doing it later on, the injury that you will cause will initiate the process of intimal hyplasia and restenosis and all that अगर खाली balloon करते हैं। बाकी drug loading balloon is always an option as well, which for ISR is an option available. ये पुराने कुछ cases हैं कुछ जिनमें stent डाला था, but ये तो खैर बहुत ही undersized था, but those are the options that and those are my thoughts on that. Asad and
लेकिन I think what Usman is trying to say कि once you had done an NC balloon on that stent that was 2.5 stent, before you had put in a new stent, you could have done an IVIS to see if there is stent fracture or not, or if your original stent has expanded enough or not. Because if your original stent has not expanded, because we know all these, even the third generation stents, anything below 3.0 doesn't go up to anything more than 3.75, and that's where your point becomes valid, that there is a high likelihood of stent fracture. But if you are not able to expand that original stent, even if it fractures, you can put it, at that point in time, you can always put in a new stent. But if you are not able to expand it, and then you put in a second layer of metal, that's probably something. It looks like a fantastic result, so I'm sure it expanded. Like in IVIS in the middle, before putting in the second stent would have really helped make your case. But this looks like it has expanded.
हाँ जी, बस उसमें यही था कि 2.5 को 4 पे स्ट्रेच करें तो देयर इज अ हाई लाइक्लीहुड फ्रैक्चर, बट इट्स अ गुड पॉइंट कि आपने एनसी करके दोबारा आईवस कर लेते बिफोर पुटिंग अ स्टेंट इन, So that's always can't go wrong with that thought. Bilkul.
But it's a great case to demonstrate that how visually your stent sizing can be so undersized, because visually they thought maybe 2.5 would be enough. And आप अभी बात करेंगे उसकी sizing on how to size on IVUS. That's another.
I think, Usman, problem hota hai when there is a vessel is diffusely diseased and you end up undersizing so much. And I've seen this so often that like this vessel is diffusely diseased distal and you start comparing with the distal vessel and then you end up putting so small stents. And we know that LAD usually is not like unlikely less than 3. So the time you don't want to put that small sizes. Just a quick question from the panelists, like in terms of left main, when you're evaluating, like what is your preferable IVUS, FFR, IFR for evaluation of the left main?
I would
If
have
you
gone
don't,
with IVUS.
obviously,
That was
you don't
my
have the
other
luxury
point.
of doing both. But if you have to do one, which one would you use?
I had actually marked these 2 points, like the case 1 and case 10. We used FFR to see if left main was significant, or if case 1 में तो सर को सिर्फ डेब किया तो that is okay. लेकिन case 10 में तो we were deciding on bifurcation strategy, and both left main to LED was positive and left main to circ was positive in case 10. So we could have done IVUS, and then we could have seen what sort of plaque was there, and could have sort of we might have gotten more information. Case 10.
Case nikala, हाँ. So this is a lady who actually came in with Wellens T waves, and LED was a LED was a significant lesion, and because of but left main borderline थी और circ का भी borderline था, तो it wasn't sure कि
आगे करें, the image दिखाएं.
ये कौन सा वाला था दिखाना. इसमें था कि वो
मतलब if you look at it in the crani view,
ये
the
तो करने के बाद
looks pretty
सो
significant.
दिस में एलईडी जहाँ इसमें लगती है, बट ये हमारे व्यूज थे वहाँ पे जो आउटसाइड जहाँ से एंजियो करा के आई थी, जो व्यूज लिए तो उसमें एक्चुअली लेफ्ट मेन का उन्होंने कहा था कि बॉर्डर लाइन और सर का भी, तो इसको ऑफर हुआ था कि एलईडी पीसीआई करवा लें, खाली किसी ने कहा था बाईपास करवा लें. शी वाज कंफ्यूज, शी डिडंट वांट बाईपास. तो हमने कहा बिफोर वी कमिट टू लेफ्ट मेन बाइफिकेशन स्टेंटिंग, कि दो कंफ्लिक्टिंग ओपिनियन भी आ गए हुए हैं, तो उसका फिजियोलॉजी कंफर्म कर लें. we're going to be doing left main PCI in this case, तो वो कंफर्म कर लें. तो इसलिए इसकी सर्क टू लेफ्ट मेन जो है वो IFR किया था, और एलईडी से भी एलईडी से सिग्निफिकेंट आना ही था. बहरहाल वो लेफ्ट मेन की कंफर्मेशन हो गई थी कि इट इज सिग्निफिकेंट. तो पॉइंट वाज के if you're going to do left main PCI, or or send them for bypass even for the left main, you should be sure. अगर कोई borderline है और जरा sure नहीं हो, तो you should confirm it with physiology. जहाँ तक committing to revascularization for left main hai, so I think physiology is probably a better way to do it. You can safely defer based on imaging. कि अगर आपका 6 millimeter square से ज़्यादा आ रहा है, I mean there's a study on 7.5 millimeter square, there's a study on 6 millimeter square, and there's an Asian data on 4.8 millimeter square, but generally I use the 6 millimeter thing. अगर उससे ज़्यादा आ रहा है तो you can safely defer. अगर उससे कम आ रहा है तो you cannot say that is significant. I would still want clinical scenario physiology to fit with that before I intervene on that left main or commit them to revascularization with CABG also. So those are my thoughts on it. I don't know, Usman, what are your thoughts on that? And
लेकिन left main stem gold standard is IVUS. You need IVUS for post optimization as well.
वो तो बिल्कुल सही है. हाँ, नहीं इसमें so there is, you can't go wrong. कि आपने इसमें so for stent optimization तो physiology is the best thing. But इसमें already IFR की भी थी, and this was a cost issue, तो इसमें खाली physiology करके फिर हमने खत्म किया था. But ये है कि yes, you can't go wrong with you know always should try to use left main के साथ.
For you, Asad, so you always evaluate left main with IVUS, don't use FFR, IFR for evaluation.
For something like this, like for I don't know, ये शायद इनको सस्ते मिलते हैं FFR वाले wires, हमें तो एक ही प्राइस की मिलती है. तो for me, I would have done an IVUS.
Generally for left main lesions, I do an IVUS. Obviously, there are exceptions. The other thing is that I'm still not very comfortable using IFR. I know there's data, but I find that the cutoff for IFR, depending on which you look at, is, if it's 0.89, 0.90, there's a lot of gray area, and especially for something like this where you have a lesion in the mid LED as well. I would probably not trust IFR and do FFR. I think आपने दोनों किए थे.
जी बिल्कुल. So what I typically do is कि intracoronary infusion तो I do intracoronary adenosine infusion तो मुश्किल हो जाती है. I know what your protocols are. Intracoronary adenosine जब use करता हूँ तो I use for right I use around 60 and for left system I use around 100. और अगर उसको tolerate करते हैं और उस पर significant नहीं आता तो मैं incrementally slightly continue to increase the dose. बट ज्यादा नहीं 150 to 200 max for left system and 100 right तक का चला जाऊंगा. और उसी पे significant अगर आ जाता है and correlates to the IFR, then it answers my question. I've rarely found discrepancy. Most of the time it correlates well. I don't know what your experiences has been in the lab, but generally I found it. But I always do FFR. जब भी IFR करता हूँ, don't just rely on IFR. I always do the IFR. But intracoronary infusion is a problem. सारा बनाना करना in the lab, but generally, yeah. If you want to go by the book, the studies with FFR were done with obviously intravenous infusion के साथ.
Yeah, we do all the time infusion. We don't use the bolus, and that's the
We
point.
use IV as well.
It doesn't happen
We
that often, but it can happen that FFR and IFR may not correlate. I think one of your case, I don't remember the number. IFR was 0.91 and FFR was like 0.79. So then, like you sometimes gets confused which one to believe. But obviously, FFR has more data than IFR, as Usman said. So I will go with FFR.
हाँ मतलब उसमें
So
I think then you have to put in the clinical picture and everything together to decide which is the right answer because वो फिर उसमें then you want to go for intravenous infusion to really get the right FFR अगर वो negative आता है उसमें इसमें इधर कोई discrepancy वाला नहीं था केस में मेरे ख्याल से वो किसी और वेसल का साथ उसने डाला होगा बट किसी में इस तरह नहीं था इस वाले में तो जिसमें discrepancy थी between the FF and IFR but you can rarely see it. Yes, I mean you will see it in
But
some
the
cases.
other issue also is that, all of this, every company has its own different algorithm. So if you're using the Philips wire versus the Volcano wire, so उनका जो IFR या Philips का जो IFR equivalent है, so the data is different, the algorithm is also different. So I'm really not comfortable कि पहले मैं काफी use कर रहा था, but I had couple of cases जिसमें there was some discrepancy. So I've now largely just switched back to using IV adenosine infusion and FFR, which I find is consistently reliable. Yes, you're absolutely right for lab throughput थोड़ा time ज़्यादा लगता है, but 5 मिनट में वो prepare हो जाती है और फिर कर लेते हैं. So that would be my only thing. And I think for left main, generally my go-to is IVL, but in certain situations would use FFR or IFR as well.
It takes less than 5 minutes actually. हमारे तो within a minute or two, they are already ready to do
which I
that.
find is potentially consistent.
Is Raza there? Dr. Raza from US was able to join?
I don't see him. I think it's too late for him.
Please start him, guys.
Awesome.
Walaikum salam.
Sohail here. I've been listening to the conversation. Some really great cases and great to see such wonderful friends and operators here. Bashir Saab, how are you? Fahim Bhai, Asad Bhai, Naman Saab, and I must appreciate Sohail's excellent cases. I mean, everything has been discussed so wonderfully well. It's very educative. The only point I'd like to add here is that for left main stem, we can do an FFR and then we can talk about the significance of, let's say, circumflex osteo and all. But in left main, probably FR would not answer the question completely because what's going to happen is what's going to happen to the circumflex after the stent inflation. So that kind of aspect has to be covered also while we're deciding about this strategy. And because left main stem is a situation where the way I would approach it is that you can't really come back to it often enough. Uh, Left main is something which you want to give it one finality and complete it. For example, if there's a moderatish circumflex, but the plaque's going to shift differently, it's going to the angle may change. Then you really have an issue, maybe recrossing, redefining the strategy, coming back a second time, re-engaging in a stented left main stem. So those kind of things are there, but I think the way you guys have discussed all this, it's really important to go through these stepwise. And I'm not sure if a bolus would ever give you the same information as an infusion, Naman bhai.
Uh,
Um, that's something, but great cases. And, you always overestimate the result on an angiogram. And when you do an IVUS, you find that you do get underdeployed, stents. And I've seen that you use different techniques for left main stem. I'm trying to go over the impression I had while I was good looking at these cases. You can use any technique you like, but as long as the IVUS shows a good result, whichever technique you use, probably like you've been using mini crush and so on and so forth, which is not a very trendy thing to talk about nowadays. But if the IVUS looks great, then it's perfectly acceptable to be happy with the result you get with the left main stem. So, and I'm amazed at the amount of equipment you've been using very freely in these cases, combining IVUS and FFR. That's really wonderful. I mean, you brought the first world to this country, which is really
So very
excellent.
valid points. If you're committing to left main, and if I was going to left main PCI, I would go with IVUS, no doubt. But if you have, if you're not sure whether to do that left main or not, I would want to use physiology along with left main as well. Because committing to a left main, unless it's more than 6 millimeters square, you can safely defer. But otherwise, you want to, if it was, use physiology as well, combine with it. And yes, if you're is a discrepancy between IFN and FFR with intracoronary adenosine, then I think intravenous adenosine should be used. But if they both correlate together, then I think it's just an unnecessary effort. If you have given intracoronary adenosine and it's giving the same result as your IFR, it's coming into significant range, then I think there's no point in intravenous adenosine. But yes, you should have that option available if your IFR and FFR show a discrepancy. Um, Meanwhile, Osman was raising the question about what is the ideal criteria for stent deployment. So I think the ultimate criteria is which I have adopted to using most commonly that try to get 5 millimeter square stent area in the vessel, non left main vessel, and it should be at least 90% of the distal reference lumen area. And where it lands, it should be in less than 50% plaque burden area, and that's where it should be, and there should be no edge dissection. And if you're looking at IVUS, the edge dissection involving the medial lens should be less than 3 millimeters. So what I typically do is that I'll calculate the stent diameter based on the lumen diameter of the distal reference. If I'm using EM to EM, I'll use like 80% of that diameter, and if I'm using lumen diameter, I'll use 1-to-1 ratio. So the distal diameter is 2.5 lumen diameter, I'll use a 2.5 stent. And if it's EM to EM, which is like, 3.0, I'll use a 2.75 size, just a little undersized if I'm using EM to EM ratio. And then after stenting, we'll post dilate the proximal portion of the stent more towards the proximal vessel diameter, and try to get the 90% of the distal reference, have it well opposed, and try to get minimum 5 millimeter square. And sometimes you'll not get that 5 millimeter square, even if you're getting 90% distance reference area, and it's well opposed, and that's okay because some people will not have that vessel size, but most people 5 millimeter square can easily be achieved and should try to achieve that. So those were in terms of the stent deployment, the criteria to use and thoughts to use. I don't know, Usman, what do you use? What approach do you use when you're using stent sizing and with IVUS?
Jeannie, thanks, Roman. I think you've gone over all the essential points. I try to use EM to EM most of the time, and then do 0.5 millimeter less than the EM measurement. So that's just generally what I've standardized to. Sometimes the EM is hard to identify, either because of the quality of the IVUS image, or there's calcium, or the plaque morphology is such that you don't see it. Then you can do vessel to vessel. And then that's, I still don't do 1-to-1 because if you get a dissection, then you're stuck maybe putting in another stent. So I still undersize by 5 millimeters, but you can always post dilate it. So I'm a little conservative in that regard, but mostly EM to EM and then half a stent size below that.
Okay, yeah, that's typically if you go with EM, it'll be half a size stent. General recommendation is also to use like 0.8 or 20% less than what you measured with EM to EM, because there's a lot of positive remodeling as well, and you can get a much bigger diameter with that plaque. So then what
There
is
is one
what
issue, Raman, if I could address and ask questions from you on that. If you have a diffuse LED, like even look at this, you can have a very thin caliber LED, and we just decided that if you can land the stent in a plaque, but the plaque burden should be less than 50%, and you obviously can't go right down to the tip and start stenting. So you put your stent in, and you got to be very careful that you don't get an edge dissection. So after you've placed the stent at a relatively lowish pressure, then when you bring it back, you can push it out and take it out to 80% of IM or the true lumen, and then do an IVUS. But so you gotta be careful about the outflow, that outflow and the rest of the vessel uh, can have a mismatch, because the outflow has to match the distal vessel. If you try and push that out, it is big likelihood that
Yeah,
you can have a dissection.
that's a
Yeah.
very valid point. So that's why it's good to undersize a little bit. You can always post dilate later. So start
What
with
we've done
80% of
lately
the EM,
is,
or you
yeah,
can
what we've
go if
done,
it's a diffusive
yeah.
disease, you can go with the reference lumen area. But ideally, you should not try to land in more than 50% black
Yeah.
burden to begin with. Now for the
What we just start doing nowadays is that once we get a diffused distal to the stent, we use a DCB to coat that area. I'm not sure if it'll help us or not, but it does look good if you run an IVUS on it. And we show you some cases. We've had some great results that we try and diffuse disease. We try and DCB. If there's dissection, we put a stent there, especially proximally, and the distal vessel gets a DCB. So a combination of DCB and there is a chance of a positive remodeling with DCB, because the stent, once it's there, it will not allow the vessel to grow beyond that. If it's a 2.5, it won't allow the vessel to grow beyond that. But there's a chance that if you use a DCB, there might be positive remodeling and the vessel may grow beyond 2.5.
so valid points. I mean, the role of DCB in diffuse disease is coming up, and good point there. So for the point of confluence and distal left main bifurcation, we used to have the traditional 6, 7, 8 thing, but in the recent paper, there was this, they changed it that MSA for the ostial LED in the point of confluence area there should be 8.3 millimeters square, and for the left main, it changed to 5.7 millimeters square, and for the distal left main, 11.8 millimeters square. The advantage was seen actually more with the LED and circ, that if you got a bigger area, then you had better outcomes. I don't know if you're targeting those areas, Asad, Bashir, paper in the JAC came out regarding that.
I think for me, ostial, this carina or whatever you want to call it, area of confluence, is always a site which we overlook. Now that we do KBI and stuff, we probably get away with it because that area automatically gets expanded a bit more than what we would get with just spot. Like I think even my own gut feeling has always been that ostial LED is a place where I would always sort of put my pot, not the last pot, the first pot. In the first pot, I would always try to get my tip of my balloon right close to the ostial LED, real close. So at least I get the tapering part of that 4.5 balloon in LED ostium, because I always felt that that's an area which remains underexpanded if you just go by the regular KBI balloon. So definitely this paper would definitely be something that I would follow.
All right. So I think the idea of these sessions was to encourage more use of imaging and physiology in our coronary interventions. It is underutilized everywhere, but particularly in Pakistan, because the cost issues is a very limited use that I've seen over here that people are doing. So what can we do as a society to increase the use of this? Any thoughts from the panelists and Sohail Saab?
I think Bashir is coming up with with a concept of reuse and restylization of this equipment, and if we can see what the guidelines are, there is a there may be possibility. I mean, we can use the same IBUS in the same patient in other vessels also.
So it's a
So
taboo question. Can I
yeah.
ask, do any of your centers reuse it?
Yeah, okay, let me tell you. I have been reviewing the literature and going through and almost written the guidelines and trying to form a committee of ID and other people to go through that. Most of the places actually, especially if it's not a tubular thing, if it is proper, the most important thing is properly re-sterilized, and there is a special whole basically algorithm criteria how to do that. And if you do that, then it should not be a problem. Again, off the record, we do reuse it, but we clearly tell the patients that if we use a new one, then the cost is this. And if you're doing a reuse, and again, that is also one of the things that you have to inform the patients that this is going to be. And by reuse, we are only actually we can use sometime up to 4 times. And it's like the cost goes down to, like, we charge the patient, I think, around 45 or 50,000. And that's true for IVUS and FFR, IFR also. So that's what has significantly increased our use of all these things. And I'm hoping that I think by Pakistan Live, I should have those guidelines vetted by all the societies and endorsed by them. And then we can probably, from our society also, council approval, and then we can publish it. And then hopefully that will help us to be able to use it. I don't know about others.
GP, so we reuse the FFR wire for 3 times. And then the cost is reduced. The patient is told that, this is a reused wire, so the cost would be 1/3. If it's new, then it's, whatever the new cost is. We don't reuse IVUS, and there's some institutional cutoff in terms of the lumen inside the catheter, how small it is, whether it's an 0.14 or 0.35 or larger wire lumen. So we generally tend to reuse devices that don't have a lumen. My only concern with reusing is that, the data for using equipment is good, but our screening practices for bloodborne infections is not consistent across all institutions. And so, larger centers may have very standardized blood screening practices, but a lot of community centers, small centers don't, and they use these kits, which don't have the same accuracy in terms of screening for Hep C and HIV. And at least, in certain parts of Sindh, we have seen breakouts of diseases. So that's something that makes me a little nervous. I'm comfortable reusing FFR because it doesn't have a lumen, it's just a wire. I'd be a little hesitant to reuse IVUS. But the cost issue is real, and it's a major challenge.
I have occasionally.
Usman sir, if I
So
may add,
FFR,
then maybe when we writing down these guidelines, we say that we describe what has to be screened for in a PCI. I mean, I know centers who, some of them do just hepatitis B, C, don't do LFTs. The others who do LFTs don't do hepatitis B, C. We as a policy also do HIVs, and every once in a while something pops up, for HIV also. So, you cannot be too complacent about these things. And if you're going to use 4 patients for the same reuse equipment, so the first one really gets the best advantage, and the others probably, there's no right or wrong, but they're getting a reused one. So if they pay the same, that is some question which is an institutional question to be answered. But maybe in the guideline we should say what has to be screened for in order for you
Right,
to use
absolutely. I
this.
think especially if you're
so
going
my
to use sorry to interrupt, Nohan, but if you're going to
Mhm.
use a device that has an 0.14 lumen, which is a really small lumen, and I think the patient that is being used on should also get screened for some basic things at that institution. Because some of these kits that people use really aren't very accurate, and you could slip through patients with HIV or Hep C or Hep B, and that could be a real downstream.
I mean, I think that's a very valid concern, but cost is also a major issue. So we should, as a society, try to find a solution about if there is an option of sterilization and reuse for these. I've occasionally used IVUS, but I've informed the family if you get a new catheter, this is the cost. And with reuse, there is a cost. With IVUS, if you're using it 2-3 times, I've not seen an image problem. But it's been a very occasional thing. Typically, I just use new catheters. For FFR, IFR wire, I've never reused a wire. I know technically that does not have a lumen, so from sterilization process, it might be easier to reuse it. I've never done it because even when you reconnect the transducers back and hook it up for remeasurement, you are having a lot of issues with getting proper measurements. With sterilization, I'm not sure how accurate and reliable those readings will be. So because they're so sensitive, those transducers, so I wouldn't use it for reuse purposes. And personally, when I have used them, I use the reused wire for them to test the system. So what I do is, for another important thing in the lab, if not they're not doing it frequently, is make sure your staff is using your FFR, IFR, IVUS system, hooking up the catheter, hooking up the machine, switching it on, doing it on a regular basis, so that when in a case you want it done, you just say, I want IVUS, and it doesn't take more than a few minutes to bring in, the machine, put in the name, and get it started. If you haven't used it for months, nobody would know where the machine is, where to hook it up, and how to switch it on, and how to put in the name and all that stuff. So if your staff should be very proficient to help you, with during the case, because your focus is on the case and you don't want to be wasting time, getting the machine started yourself and all that stuff. So I was asked to go do IVUS in a center somewhere else, and I went there. The IVUS machine had been there for 1 year, and when that day they tried to open up the IVUS machine, तो चूहों ने कतर लिया हुआ था तार को. तो so that's the thing. If you have the equipment, utilize it. And a lot of the government centers have it, but it's still even underutilized over there. And they have inventory as well available, but still it's not being used as frequently as it should be, despite it being a class 1 recommendation for left mains and complex lesions. So I know we do it sometimes without imaging and left mains because of cost issues, and that's okay. But wherever we have a chance, at least we should offer it to our patients, that it can have an impact on long-term outcomes and hard outcomes with MI and death. So those were my thoughts in terms of the thing. So yeah, Bashir sir.
As I told you that we have been using FFR, IFR for a while now, and as I said, 3 to 4 times easily without any problems. And whenever we think there is some issue, we don't like the waveform, or we think looking at it, it's bad, and we have tried to, actually initially we compared actually new and reuse number. We used to do, like when we started, we used to do with the new one, and also try to reuse one and see if they are comparable or not. And we did not have any problem with any of them. And obviously, as I said, that equalization or zeroing and all those kind of issues, you can see if there is a problem with the wire also, they won't zero or equalize also. So we did not have a problem. But again, the thing is, I think, as I told, there is like India, there is also a paper on reuse guidelines, published one, and they have been actually using even the tubular structure, especially PTMC balloons, and I think a lot of our government institutions, and sometimes rarely, we do use the PTMC balloon because of the cost issues. And they did, again, the data did not show any increase in problems in those patients, whether in terms of infections or anything else. So I guess, I don't know, they most of the time say that Hep C or B or HIV, they don't stay in the kind of environment after you leave it for a while, even on the surfaces. But I guess the most important thing, as Suhail said also, is it's going to be very, very important to have the proper process of re-sterilization, and that's, I think, and that should be actually, ideally, they say it should be certified. And so those places who will be doing it, they have to demonstrate they have adequate process of re-sterilization in their institutions.
Yeah, that'll be crucial to just have a strict parameters, what the testing should be, what routine testing they're doing pre-cath, and what is the sterilization process if that reuse thing is allowed. And the patient should be consented and informed about that as well. And obviously the cost will be much lower for them, or free, if it's a reuse thing, and approved with proper guidelines. So I think with that, we have a good, interesting discussion on IVUS and imaging, and hopefully these sessions will encourage more frequent use of this, since it's a class 1 guidelines in both ACC and ESC. for it to be used for left mains and complex bifurcations, stenting at least. And on that note, we'll end today. Everybody have a nice weekend and Ramadan Mubarak to everyone. And thank you again, Bashir Saab, Usman, and Asad. Excellent talking points, and Sohail Bhai as well for joining in and giving your thoughts. So have a nice weekend, everyone.